testing, but also cognitive training. And this cognitive training increases the research interest. Many researchers would like to know if cognitive training can help these patients, and many of them would like to commercialize these computerized machines in order to help also their pocket. And the vast majority of medical doctors, but also the people from informatics, focus in order to prepare ease of use and enjoyment for these old people who want also to have an examination, but have also to do training. These cognitive tests do assessment of specific cognitive functions. They can do screening for cognitive decline, and also they use widely virtual application like virtual supermarket, which is an ecological application. So we would like to see the needs the old people have in order to go on with this computerized technology. We know that in everyday clinical practice we use trained neuropsychologists, and we need long-term assessment, and is not good for our patients. So there is a big need in order to find reliable and valid cognitive tools which can help us in order to finish very quickly our examination and say to the patient if he has or she has problems with his or her memory, cognitive functions like executive functions, meditation, and abstract thinking, and so on. And the vast majority of research in this field is in preclinical stages of Alzheimer's disease and dementia, in order to succeed to prevent or slow neurodegeneration. And but always we need the use of costly, non-invasive biomarker screens, and this could be a success if we could succeed to have a neuropsychological examination in computerized way in order to not have CSF or PET and so on, which have a high cost but also are invasive. How is now the ICT research in the world? There are four arcs. The first is we have to prepare continuously better diagnostic instruments, and also we have to prepare assisted living, and here you can see a robot and a smart house. We have prepared a smart house in our city, not in the campus of the university, but in another research area. And also we succeeded to have programs where we do cognitive and physical training together. This is a program which was funded by the European Commission. And also we prepared with money from Ministry of Education support platforms like this for caregivers and patients at the very early stages. And about assisted living, I have to say only some words. We have prepared smart home systems. Now there is a big one and a smaller one in our university, where we use sensors and wearables and monitor daily activities and compliance to treatment. And also we can detect dangerous events and alerts if the patient falls. And also, we have done much work with assistive robotics. We didn't reach Japan in this field, but we try to have robotics which can help us in assistance and in activity monitoring in everyday life of our patients. You can see here different robots which we use for assistance, monitoring and socialization. And the vast majority of older people would be very capable of using new technologies if it was not designed by younger people for younger people. That means that we need old people to help us in order to design new technology for elderly people. And this is another program we run now, the BRIDGE program, where we have together young people with old people, and they design serious games for old people. But the suggestions come from the old people, and this program is called BRIDGE. What do we do in Greece now? There is a plethora of research projects utilizing new technologies, informatics and communication technologies, is the ICT. We try to use these new technologies in healthcare services in our day centers, and we wrote down which are the attitudes of older adults toward ICT. And we see that these attitudes are changing during the time. When I first tried to touch this field, I saw that in Greece we have only 5% of elderly people who use computer. And now this number is increased, while at the same time in the United States, I found in 2013 about 86 of elderly people used computers or smartphones or internet. These are the programs. These are the programs we have run. I'll say some words only for each one because we have no time, and these also are programs. And I'll start with virtual supermarket. Visual supermarket was designed in order to help people to do a work which they do, they did in every day. It is a cognitive testing. That means that computerized cognitive testing can detect MCI, mild cognitive impairment, but they need examiner. All these 18 computerized tests I showed just before, they need an examiner, and also even computerized cognitive testing is boring sometimes. And also the same would say about computerized cognitive training. We have to prepare for our patients enjoyable and engaging training, which could be self-administered. They could take their smartphone and they could do cognitive training alone in their room without feeling boring. And perhaps this cognitive training sometimes can detect MCI and sometimes cannot detect if they are not well designed. And what about visual supermarket? It is enjoyable, it is engaging, everybody can do this. It is self-administered and also can detect mild cognitive impairment. There is a purpose, a structure, and rationale for this visual supermarket. We have no time, but if somebody is interested in doing this cognitive testing and also cognitive training with a visual supermarket, we can collaborate. It is now translated in many languages. And Turkish people have two studies with this visual supermarket. We translated in Turkish, and also it was translated in Italian and in German. And I would like to show you only the sensitivity and specificity. This was the first supermarket was published in 2003 by Jewish people, but it has no results. However, our virtual supermarket, which the first tile is in this picture, but you will see the better pictures. And what we measure with this visual supermarket, we measure time one person needs in order to buy the things that we suggest to him. We measure the mistakes, trajectory and navigation, and the practice effect. And the first study was with 55 subjects. And we succeeded sensitivity about 82% and specificity 95%. And we went furthermore, and we used another version of supermarket, which I used only in 12 participants, but 6 were healthy and 6 were MCI, mild cognitive impairment. They used 20 administration only for screening in methodology, and we measured the same things, and we found that we have a distinction between healthy and MCI, very good distinction, and these are the metrics. And we succeeded better sensitivity. You see 94 and 89. In the morning I discussed with you and said that the best biomarker has to have a sensitivity more than 85%. You see that a computerized test is very useful because it is a very good biomarker. And this supermarket had a very good correlation with other tests. Here I show you the TEA test, which is a cognitive flexibility symptic attention test, and also Ray Osterreich test, which examines visual spatial abilities. There are limitations, as in all tests. Does not replace traditional neuropsychological testing, but we hope that in future we succeed also this. And until now, where I believe that even in Egypt, as in Greece, we have many people, old people, who are familiar with computerized science. And I would like to go with another computerized test. This is the new supermarket, the new version of supermarket, and now we did a correlation with another test which Americans prepared. This is the brain health assessment. They took $5 million in order to prepare this test, and we took only 200,000 euros in order to prepare this supermarket. We prepared now 2 studies with this visual supermarket. They prepared 1 study, and now we finished the study where we compared these 2 computerized tests in order to see which is the better. Yes, okay. And this is the test, the American test, where they show different persons with different colors and different smiles. And then they have, the old people have to match these persons with favorite animals or favorite occupation and so on, and this duration is 10 to 15 minutes. There is another computerized test. The name is Altoida. We used also in our patients, and the researchers who prepared this test in the University of Zurich say that this test can predict Alzheimer's disease 10 years before the onset of symptoms. It is a test which has a duration of 10 minutes, and the diagnostic accuracy reaches 94%, a very high sensitivity. Another project which was funded by European Commission is the long-lasting memory, which is a combination of physical exercise and cognitive exercise. Some picture from this program. This is the flow chart, this is the participants, this is what we did with the body exercise. These are the results which published in 2015. And another program is AD gaming. This program is in Erasmus Plus calls. 5 countries were collaborators, as we discussed just before. Today, one person as clever as he can, as he cannot publish studies alone. So we have to collaborate all together. These are the groups in different cities where we have the meetings, and we had to prepare 5 serious games. Each country prepared 5 serious games in computers. And finally, we prepared 25 computerized games, and all these games are on our platform. You can find them, you can translate them, and you can use also in your country. These are the serious games. You can take the slides also, not only to be in the site. And we had also we did give these serious games to patients, and we found that they enjoy and they have improvement in cognitive function. These are the groups. I finished. I hope this, and this is the platform and the pictures. This is the platform, and I would like to finish with the last achievement we have. This is a remedies game, which is very useful to separate healthy people from subjective cognitive impairment and subjective cognitive impairment from mild cognitive impairment. Also, it is a collaboration with engineering department of our university. It is the design of this training application is published now in October 2019, and here we say that they can. And I would like to show you what is this. The patient has these patches in front of him, and different colors and different lights and different animals. They appeared in front of him, and the patients have to change their mind according to orders they have from the psychologist. And finally, we have prepared a myth from Hagia Sophia. This is a church in Istanbul, and we use it for people who are refugees from Turkey in old years. This is the myth. We have no time to show this. There was no big sensitivity specificity, but we try now to improve this sensitivity and specificity, doing it as computerized. We succeeded to have the computerized test, and now we have to see if we succeed better sensitivity and specificity. All these things are in agreement with other studies all over the world. For example, this study sent to me in order to review it, and you can see the title, Gallery Games, Smartphone-Based Assessment of Long-Term Memory in Adults and Risk of Alzheimer's Disease. These are some pictures of this, and the last slide is what I found these days, and it is very interesting, that if we use new technologies, new machines, which are prepared from the informative people, then we can separate different diseases with a very big accuracy. And you can see that here with our projects and this project, this comes from the Netherlands, that the collaboration between medicine and informatics can be useful for our patients. Thank you very much. I would like also to show what we have done for caregivers. Psychoeducation, support groups, family therapy, relaxation techniques, and online support. This is a picture of online support. Caregivers are at their homes, and the psychologist here does the education. The results are very interesting, is under publication, and I would like to thank all the participants, all the patients, all the caregivers, and my colleagues here, and say thank you also to you. I didn't succeed to finish at 20 minutes, but I tried. Yes. Okay, are there any questions?
Just one thing very quickly, when you talk about the supermarket, is visual reality here.
Yes.
So people have the visual reality, which we use in games now, yeah?
Yes.
And does by any chance increase confusion? Did you test for disturbances in orientation or
Yes,
following
this all training or assessment tests we use is subjective cognitive impairment in healthy controls all the patients, but also in my cognitive impairment, not in dementia patients. Dementia patients cannot do all this. We tried, but they cannot succeed.
Thank you so much, Professor Magda. We enjoyed much. We together to try to apply these tools here.
Yes. Did you translate the supermarket?
Working on it.
Okay. So it will be ready in Arabic also.
Yes.
Supermarket. Yes.
Now we invite Professor Nurullah Hussain for her coming lecture. Hospitalized at the
أولا أنا بحب أشكر اسمي ساكايتي على الكولابوريشن مع التك ماديسن، يعني I hope إن احنا نبتدي إيرا جديدة من new model of care for supplying geriatric service في القصر العيني. النهارده I want to speak about the hospitalized elderly. Elderly في الكوميونتي أو في الكوميونتي based is another problem than the hospitalized elderly. Worldwide population are aging, and older people represent the fastest growing sector of the community and is the success of the society. في مصر الجهاز آخر إحصائية للجهاز المركزي للتعبئة والإحصاء قالوا إن Egypt reaches الelderly in Egypt reaches 6.5 مليون. الستيتمنت دي كانت في سبتمبر 2019 وكان منهم 3.5 مليون males and 3 مليون females. وعجبني كمان في الستاتستيك دي منهم 1.2 are still working. فوق الستين. دي آخر إحصائية والعدد كده تقريبا 6.5%. كلهم يعني أو عدد محترم منهم 1.2 is still functioning وبيشتغل فده عدد كويس. But not everyone is successful. الelderly دايما عندهم probability أو increased susceptibility to disease and decreased ability to compensate. هدفنا كجيرياتريشن وهدف المريض طبعا to keep him functional and independent. الالتيميت جول انه يبقى healthy aging but at least control health issues. Health issues في الelderly بتبقى coronary heart, high blood pressure, diabetes أو arthritis. كمان الsensory defects الفيجن والhearing المفروض الحاجات دي كلها تبقى controlled عشان يبقى functional and independent. What happened in hospitalization? Hospitalization is a threat for the elderly. 75% of patients 75 years and older who are functionally independent at admission are not functionally independent when they are discharged. Hospitalization per se results in complication which is unrelated to the problem that caused admission or to the treatment of this problem. So hospitalization equals functional decline, and all of us know that functional decline equals higher mortality. The threat in hospital or the hazards in hospital are falls, delirium, and other cognitive dysfunction, infection or the common infection, adverse drug reaction, and pressure ulcers. Who will get the functional decline? There are risk factors before admission and risk factors related to the hospital. Before admission, increasing age, the older, the worse the outcome. Low functional capacity at the beginning or at admission, the low activity of daily living or the instrumental activity of daily living, the cognitively impaired, the depressed with comorbidities, especially pressure ulcers, who has malnutrition risk. The hospital is not safe for the elderly. It's a disorienting environment. It's a noisy environment. It disrupts sleeps, discourages motility, exacerbates disorientation, leads to social isolation and increased falls. Why are elderly patients especially vulnerable to this functional decline during hospitalization? There is an interaction between the physiologic impairment with age, the adverse hospital environment, and the pathophysiologic impairments from this disease. أنا همشي بسرعة عشان الوقت، فأنا عايزة أقول لكم الانتراكشن. أهم حاجة في الهوسبيتال environment restricted mobility. Bed rest. Restricted mobility due to bed rest orders. The doctors بيقولوا للعيان استريح في السرير برغم إن ده ما أثبتش فايدة قوي. Limited access to bedside chair. بتلاقي أوضة المستشفى فيها سرير بس. ممكن كنبة أو حاجة، لكن مفيش سرير المريض يقعد فيه بقية اليوم، مش لازم يبقى قاعد في السرير. الهاي beds. High beds also have been found to be for the convenience of the staff, not for the patients. Getting out of the high bed or getting into the high bed predispose more to falls than falling from the bed. The use of restraints, intravenous poles, urinary catheter, ventilators، كل دول بيربطوا العيان في السرير فمش بيبقى قادر يتحرك. Bed rest effects on the cardiovascular system, increase the stroke volume, the cardiac output, decrease the plasma volume, and this leads to orthostatic hypertension and risk of syncope. Respiratory, there is restricted chest wall movement from the recumbency position, and this leads to low oxygen tension. And there is muscle strength weakness. This, I will show you how this is interacting with the physiologic changes with ages. There is increased or accelerated bone loss, decreased appetite, anorexia. الأكل في المستشفى مش قد كده appetizing. زائد إن طريقة الأكل نفسها في المستشفى السرير في الترابيزه في السرير والطريقه، اكل ممكن يبقى بعيد عنه على ما يوصل له يكون بارد، فده بيؤدي اكتر للانوركسيا. urinary incontinence في الهوسبيتال بتحصل على طول. الالدرلي to compensate for the tendency for incontinence بيعملوا program to evacuate regularly. فالمستشفى ده مبقاش feasible وبالتالي بيبقوا developing incontinence. Skin, the shearing force of the hospital beds predisposed to skin breakdown. The social isolation predisposed to depression and disorientation and confusion. اللي بيحصل كده changes with aging. Already he has reduced muscle strength, vasomotor instability and baroreceptor insensitivity that predispose to syncope. The reduced muscle strength when combining with the immobilization and the high beds and rails results is deconditioning and fall. The vasomotor instability and the baroreceptor insensitivity decrease plasma volume due to hospital beds and inaccessibility to fluids, predisposed to syncope and dizziness and is predisposed to fall. The reduced bone density already present in the elderly combines with the accelerated bone loss from the prolonged recumbency. It's not even prolonged. It has been found that the contribution of hospitalization and bed rest starts from the second day of hospital stay, result in increased fracture risk and fracture. Reduced ventilation already present in the elderly from the costochondral junction calcification and the weak muscles together with the recumbency decrease more the oxygen tension, reduce oxygen tension which predisposed to syncope. There is reduced sensory continence. العيان بيروح المستشفى ناسي النضارة، ناسي السماعة، وبالتالي ده مع الايزوليشن بتاع المستشفى بيديسبوز اكتر للديليريوم. في المستشفى كمان مفيش مجال انه يعرف النهارده ايه او امبارح حصل ايه، وبالتالي ده بيعمل الدي كونديشنينج اكتر والديليريوم. زي ما قلنا البيشنت اوريدي عنده تندنسي تو urinary incontinence في المستشفى، الباريرز والتيزرز بريديسبوز functional incontinence. هندي مثال case 1 Mr. A.H. 75 years. He was admitted to hospital after a 1-week history of increasing dyspnea. Before admission, he was receiving no medication. He had no clinically significant medical history. He was still working, and he walked up to 3 kilometers daily without difficulty. In the last week, he was starting dyspnea. In the emergency department, he was diagnosed as congestive heart failure. بدأوا dialysis, diuretics, حطوا كاثيتر طبعا، hospital ادوا فرسمايد، بعد كده حصل hospital admission بعد الاي دي. كملوا على الفرسمايد، كملوا طبعا باليورينري كاثيتر، أخذ lisinopril for systolic dysfunction, omeprazole for routine stress ulcer prophylaxis, and temazepam as needed for relief or insomnia. روتين ما بنعمل في المستشفى. For patient comfort and convenience, he was advised to rest in bed during the first 48 hours, and the inguinal catheter was left in place. Hospital day 3, المفروض العيان يخرج لكنه جاله sudden confusion. In his agitated state, the patient got out of bed and fell. بس luckily, the radiograph showed no evidence of fracture. Workup for delirium revealed pyuria with the antibiotics after example. Cultures showed E. coli in the blood and urine, Caninifibacterium. On day 6, Clostridium difficile diarrhea from the antibiotic developed. The patient was treated with metronidazole. كانت النتيجة بعد ما كان يخرج ثالث يوم، العين قعد 21 يوم في المستشفى. He was forced to retire. بعد ما خرج he was totally dependent. كمان فضل عنده impaired cognition. ده الكاسكيد of events اللي بيحصل في المستشفى. طب كان ممكن نعمل ايه احسن للعيان ده؟ مبدئيا ما كانش محتاج قسطرة. ما كانش محتاج يقعد في السرير، كان ممكن يتحرك ويروح الحمام اتليست. اوميبرازول ما كناش محتاجينه. اوميبرازول وجد انه بيزود الانسيدنس اوف انفكشن، chest infection، لان الاسيديتي اوف الستامك مطلوبه. وبالتالي ادينا انتي بايوتيك، والانتي بايوتيك جاب الكوليسترول. لو ما كناش ركبنا قسطره ما عدناش العيان في السرير، كان العيان خرج بعد 3 ايام وما كان probably still working and still active. Tiny case, 78 years old woman, type 2 diabetes. She was admitted for cellulitis on the top of the right foot. Seemed to start spontaneously. No improvement after 1 week outpatient antibiotic. 3 days of increased pain and redness and unchanged localized swelling, no fever, chills, and no open wounds. She was not able to give an estimate of the highest or lowest blood glucose in the last 2 weeks. Present medical history of medication هي type 2 diabetes كان الهيموجلوبين A1C 8.5, no history of microvascular disease. الدراجز كانت ماشية على metformin 500 mg twice daily and glyburide 10 mg once daily. كمان هي هايبوثيرويد تاخد التروكسين 100 مايكروجرام. الدكتور بتاعها زوده لما لقى TSH 8 2 months ago it was increased to 150 micrograms. For hypertension she was receiving lisinopril 40 mg once daily. In the hospital, physical examination revealed 27.4 degrees centigrade temperature, heart rate was 90, blood pressure 150/85, respiratory rate 12. She was not toxic. الألسر كان شكله مش complicated أو cellulitis was not complicated by ulcers. ما كانش فيه أي مشكلة حتى في التايم up and go test كان نورمال. والبلاد جلوكوز بتاعها on admission كان 188. YBCs كانت 9000 mostly neutrophils. Day 1 she started vancomycin in serial examination. For pain she received acetaminophen. For type 2 diabetes they continued on the home medication targeting good glycemic control. For deep venous prophylaxis she received Claxan. First day in hospital she could not sleep. She received Zolpidem علشان non-benzodiazepine are safer. Hospital day 2, she was not oriented to Mansourier. She knows her place, but she was not oriented. Blood glucose was 54. Other labs normal, renal functions were normal. She started glucose 50%, and we halved the dose of glyburide to 5. After 45 minutes, she regained consciousness and she was fully oriented to time and place. On the night of the second hospital stay, she complained of itching and she received antihistaminic hydroxyzine 10 mg every 6 hours. On day 3, she was disoriented again and the pulse was 100 and it seems irregular. Blood glucose was 55, the ECG showed AF. Anger rate was 98. So what's going on? واحدة تانية من الأدفيرس the most likely cause الاقتراحات اللي عندنا is polypharmacy from the analgesic and sedatives. It may be it's an adverse drug event from the antihistaminic, maybe, or from the forced adherence with adverse effect from outpatient medication. Polypharmacy could justify the delirium but could not justify hypoglycemia والAF. فيبقى أقرب حاجة هنا هو forced adherence. الألدرلي عادة مش بيمشوا على العلاج برا المستشفى. في المستشفى بنديهم العلاج بمنتهى الضمير فبتكون النتيجة إن يجيلنا السايد إيفكتس بتاعت الأدفيرس دراج إيفكتس بتاعت اللي كان المفروض لو حصلت برا. هي راحت للدكتور كان TSH بتاعها مش مظبوط فزود الثايروكسين فإما زودتوش أساسا ما كانتش بتاخده والTSH كان أبنورمال عشان مش بتاخده وبالتالي التوكسين كان كتير واديناه واخدت دوز مش محتاجاها وجالها. دي حاجه تانية من اللي بتحصل في المستشفى. طب هاو تو امبروف الاوتكم؟ اول حاجه واهم حاجه في الكورنر ستون فور جيرياتريك هو الكومبريهنسيف جيرياتريك اسسمنت. تايدنتيفاي بيشنت ات ريسك فور فانكشنال ديكلاين وبتايدنتيفاي هنعمل ايه في المانجمنت علشان يبقى تارجت للبيشنت. لازم الكومبريهنسيف جيرياتريك اسسمنت ينكلود الاكتيفيتي اوف ديلي ليفينج، الكوجنيتيف فانكشن، الفيجن والهيرنج، السوشيال سبورت اند سايكولوجيكال ويل بينج. ما يبقاش فيه ديبريشن. الديبريشن كمان كتير بيجو ان نوتست. We perform the comprehensive genetic assessment initially and ongoing during the hospital stay during the product علشان to identify any decline and the risk for decline. We have to target the risk factors that, like cognitive impairments, functional impairments. We have to modify the physical and functional environment the patient is in. نمرة حاجة أول واحد ambulation يستحسن إن elderly to stay in a low bed without things. إنه ال way to the bathroom يبقى lighted ويبقى في proper lighting ويبقى العيان عارفه to help him to the bathroom. يبقى في hand rails في hallways. إذا كان if he's using walking aids تبقى available. Minimizing of teasers. Not everyone needs intravenous fluids. Not everyone needs urinary catheter. Increased sensory stimulation by proper lighting. Attention to glasses at hearing aids لو نسيبهم في البيت لازم يستعملهم. ممكن كمان يبقى في newspapers أو books أو حاجات دورية تعرفوا احنا النهارده ايه. أو available recreation لو في TV في الأوضة بتاعته. يكون في clocks وcalendars. الفانكشن كمان لازم يكون daily rounds of multidisciplinary team. This is very important. والمالتي team لازم they have to share their objective. اللي بنشوفه في المستشفيات ان بيمر على العيان النهارده cardiologist writes notes النيرس بتنفذها او الريزيدنت بينفذها وبعد شويه بيمر urologist يكتب other notes وتتنفذ. مفيش shared objectives. ممكن حتى ده predispose to the adverse drug effects. ف they have to have regular rounds multidisciplinary team مع بعض to share the objectives for the care. Preventing catheter-related urinary infection is very important in the elderly hospital. It can be a restraint. الريسك بتاعها أولاً is a restraint بتخليه ما يتحركش. حاجة تانية rate of colonization and UTI is high with the urinary catheter. كمان it can lead to traumatic urethral injury. The indication of catheter in the elderly is for acute urinary retention if there is incontinence at the end of life. Or if there is need for critical monitoring of the fluid input and outputs, أو in the preoperative. لو حطينا الكاتيتر نحاول بقدر الإمكان نشيلها بسرعة. Adverse drug effects. واحنا بنprescribe for the elderly we have to choose the safest option and the minimal number of drugs. أي elderly بياخد أكتر من 8 drugs he has an 85% risk of developing adverse drug effects. Some drugs are particularly needs attention from an anticholinergic, proton pump زي ما قلنا والبنزودايزابين والنون-benzodiazepine. الانتيكولينرجيك بعضهم is unavoidable زي الدايوريتكس زي البيتا بلوكرز لكن بعضهم ملهمش أهمية زي الانتيسبازموديك ملهمش proven efficacy ويستحسن احنا ما نستعملهمش. بروتون بامب بنستعملهم في حالات معينة لو البيشنت on mechanical ventilation لو عنده gastrointestinal bleeding أو is treated for duodenal ulcer existing أو taking non-steroidal anti-inflammatory. Benzodiazepine is a non-risk for falls and the non-benzodiazepine are recently also recognized as a non-risk of falls in the discharge planning. ده آخر slide خلاص ماشي. discharge planning is very important في الهوسبيتال كير لان احنا بنكتفي بان احنا خلصنا الهوسبيتال ما بيهمناش العيان خرج عمل ايه في البيت. مهم قوي ان الكير جيفر يبقى ترينز على العلاج اللي العيان هياخده. مهم ان احنا لو علشان نمنتين الفانكشن لو هنعمل اكسرسايز تريننج لازم الكير جيفر يعرف هنعمل ايه كفيزيكال اكسرسايز. لو هيروح على نيرسينج هوم برضه لازم يبقى فيريتل سمري ايه اللي حصل للعيان في المستشفى وايه ريكومنديشن.
Fantastic. I was really enjoying every word. I just could not agree anymore. It's just wonderful, wonderful. And that is that holistic approach to the patient, which we try to apply. Questions for Dr. Mahmoud?
Thank you so much for your presentation. I would like to ask you about the preparation of the unit for receiving. You can prevent a lot of problems
في جيرياتريك يونتس طبعا لو في جيرياتريك يونتس بتبقى دي احسن في جيرياتريك يونتس في راس العين بس it's not equipped to the best of the performance للجيرياتريك patient. وطبعا the whole world is developing new models for care ونيو جيرياتريك يونتس اللي هي بتارجت الهدف بتاعنا اللي هو احنا نحافظ على الفانكشن يعني العيان داخل على رجلين يخرج على رجلين. لكن البرزنتيشن بتاعتي كان الهدف منها ازاي نحسن الانفايرمنت على الظروف اللي موجوده دلوقتي. واهم نقطه هي ازاي ندرب الفيزيشن او الهوسبيتاليست اللي شغالين دلوقتي على الجيرياتريك كير. مش كل الجيرياتريك بيشنت هيبقى ادميتد في الجيرياتريك كير، ما هو هيدخل الجراحه مثلا، هيدخل العظم، هيدخل المسالك. فاحنا عايزين نريز النولج دي او نوزعها عند الناس كلها ان الجيرياتريك بيشنت مش اول ما يدخل نركب له اصلا، مش اول ما يدخل نركب له محل، مش اول ما يدخل نديله بروتوكول علشان ما يجيبوش. فهي هو ده اللي كان هدف النهارده احنا بنتكلم على الجنرال هوسبيتال مش على جيرياتريك كير. طبعا دي الاوبشن.
ممكن أعيد الهدف التي لا يعني بس الهدف ان العيان الجيرياتريك patient gets the best care wherever we are. في المساحة في الجراحة we get the best care and we have to train people to reach that level. Not to be geriatricians, they will never be geriatricians, but to upskill them to be able to support the patient.
Yes, but they need the help of geriatric multidisciplinary.
انا بحلم ان احنا نبدا في الايرلي انترفنشن يعني before admitted to the hospital to decrease the minimize the admission.
طبعا هو زي ما انا قلت هنا ان الهوسبيتال از ريسكي بليس فور ذا elderly. كل ما نقلل الهوسبيتاليزيشن يبقى احسن. وحتى من قبل كده في الراوند ديسكشن كان في حد بيقول احنا عايزين نزود لهم الافيلابيلتي اوف اي سي يو. اي سي يو دي اسوء مكان ممكن يروحوا للelderly لانه غالبا بيخرج بديليريوم وبيخرج بكارديو غير الفانكشن كمان. يعني
لو كمان ستريكت ميشن كرايتيريا تقول يعني وانس انا عندي ستريكت ميشن هو بيأديت خلاص الدنيا واقفه. وكمان اي سي يو ولا اكسبيشن
حلوه قوي كمان علشان نحقق الهدف ده محتاجين ان احنا نحسن بقى البرايمري كير. محتاجين ان احنا نعلم البرايمري كير.
Any other questions? I have to say I enjoyed the lecture really thoroughly, but I enjoyed more the visual. So thank you so much. Thank you.
Lunch time.